Ms. J, a 58-year-old lady who presented with history of low-grade fever for 4 days a week back, history of multiple joint pains including the small muscles of the hand, elbows, shoulder and knee and ankle joints, and some muscle pain which was predominantly present in the bilateral forearm and feet for a week. She also noticed sudden onset weakness in both feet and the hand with symptoms of inability to walk or hold slippers, inability to lift heavy weight or do fine activities with the hands. She has associated tingling and paresthesia in the bilateral hand and the feet. Both these symptoms started at the same time in the feet as well as the hand within 1 week of fever. She felt that the limbs were loose or heavy and she had some pain in the calf muscles and distal forearm muscles. There was no diurnal variation of fatigability. There is significant history that she was diagnosed to be asthmatic for past 7 to 8 years and has been on MDIs intermittently. On examination, she was conscious, comfortable, oriented. Her pulse rate was 80 per minute, blood pressure was 120/80, respiratory rate was 44. She was afebrile. She did not have any oral ulcers, photosensitivity, rash. No thyroid swelling was present. There was polyphonic wheeze in all the lung fields. On CNS examination, higher mental function and cranial nerves were normal, fundus was normal, lower cranial nerves were normal. Motor examination revealed wasting of the thenar and hypothenar muscles, weak hand grip. There was no fasciculation seen. Reflexes in the upper limbs, supinator was weak but biceps was present. Lower limb, bilateral foot drop was present and she had a high stepping gait. There was weakness on plantar and dorsiflexion, inversion eversion was 2/5, FHL was weak. Ankle jerks were absent in the right and it was diminished in the left. Plantars were mute. There were no other signs of skull spine abnormality, no localized spine tenderness, no neurocutaneous markers. On history, she had and examination, she had a asymmetric distal predominant sensory motor neuropathy with element predominant signs with no bowel bladder involvement. Anatomic localization, it could be a neuropathy, neuromuscular junction, myopathy, anterior horn cell involvement or a plexopathy, radiculopathy. She had a sensory motor involvement with distal predominant element signs and asymmetric involvement which could be more in favor of a neuropathy. No diurnal variation ruling out a neuromuscular junction involvement. There was muscle pain but that was not the predominant complaint and she had associated distal predominant, not a proximal predominant muscle involvement. She had sensory involvement also, no lower cranial nerves were involved, so anterior horn cell was less likely, and she did not have any radicular pain radiating down the leg suggestive of a radiculopathy. The differentials considered were autoimmune like a vasculitis or associated with systemic autoimmune disease like SLE, metabolic B12 deficiency hypothyroidism, systemic illness associated, paraneoplastic, infections like HIV or Lyme's disease, drug or toxin induced, and hereditary causes. On investigations, we found that her hemoglobin was normal 12.8, total counts was elevated 26,100 and eosinophil count was 56% of the total count. Absolute eosinophil count was 1,700. ESR and CRP were elevated. RF was also elevated but CCP is negative. Complements were normal, ANA was negative and dsDNA was also negative. Bone marrow showed a hypercellular marrow with eosinophilia. There was no specific lesion, there were no abnormal cells seen. Other causes like B12, folic acid, TSH were all ruled out. CPK was in the lower range. She was not a diabetic. BBVS was negative. We did the definitive tests for diagnosis thinking of a neuropathy, EMG, NCV and a muscle biopsy. EMG showed reduced CMAP and sensory nerve action potential. Needle biopsy EMG showed some fibrillation in the sample muscle which was in the peroneal muscles. So this was consistent with the asymmetric sensory motor axonal neuropathy. The nerve muscle biopsy, skin biopsy showed evidence of vasculitis. There was thickened vessel seen with inflammatory infiltrate and the muscle showed some mild atrophy and fibrinoid necrosis at vessel site. So based on these investigations so far, it looked like a vasculitis, probably an eosinophilic vasculitis with history of distal sensory motor neuropathy and history of asthma. So we were thinking more of like a Churg-Strauss at this point. ANCAs were however negative. To rule out other organ involvement, we also did a urine 24-hour protein which was slightly elevated in the subnephrotic range. Dysmorphic RBCs were 4%. Her chest X-ray was normal, there were no infiltrates, and X-ray PNS was also normal. According to the ACR criteria, the diagnosis of a eosinophilic vasculitis depends upon fulfillment of any of these 4 criteria. First is peak peripheral eosinophilia, more than 10% of WBC count. She fulfilled that criteria. Peripheral neuropathy attributable to a vasculitis, this was also present. Transient pulmonary infiltrates were not there. Paranasal sinus abnormality was not there. Biopsy was showing eosinophil infiltrate, and she had asthma. So she had 4 criteria which she was fulfilling the ACR criteria. Eosinophilic granulomatosis is nothing but Churg-Strauss. Now it's renamed as eosinophilic granulomatosis with polyangiitis. It's an ANCA associated vasculitis, but ANCA is positive only in less than 30% people. It has 2 forms. One is the predominant vasculitic form and the second one is the predominant cardiac involvement form. The vasculitic form usually presents with alveolar hemorrhage or glomerulonephritis or peripheral neuropathy. The proposed pathogenesis is that the antigen presenting cell reacts with the T cell receptor, which stimulates Th2 cells, which further secrete interleukin 5, 4 and 13. Interleukin 5, 4 and 13 stimulate eosinophils, which invade different tissues and cause injury. The eosinophils themselves secrete interleukin 25, which causes stimulation of more Th2 cells and production of more eosinophils. The epithelial lining, which is present inside the nasal mucosa and the sinuses, also stimulates Th2 cells, which produce more eosinophils. There are 3 phases of illness. One is a prodromal phase, second is eosinophilic phase, and third is a vasculitic phase. So the prodromal phase usually presents with atopic disease, allergic rhinitis or asthma. This can precede the vasculitic phase by almost a decade, 10 years also it can precede. Second is eosinophilic phase, where there is peripheral blood eosinophilia and infiltration of various organs. Third is vasculitic phase, which often presents with non-specific constitutional symptoms like fever, weight loss, malaise, and specific symptoms of vasculitis like neuropathy, systemic symptoms. This is a review which was done for symptoms of people who have Churg-Strauss. Most common symptoms seen in different studies was asthma. Nasal paranasal sinus involvement was the second predominant one, and the third predominant involvement was the peripheral nervous system in the form of mononeuropathy or mononeuropathy multiplex or distal symmetric polyneuropathy. Investigations commonly reveal a positive ANCA or absolute eosinophil count more than 1500 and EMG NCV which was consistent with what the patient had, that is decreased sensory action potential and compound muscle nerve action potential. EMG can sometimes show some fibrillation potentials. The definitive diagnosis is by a biopsy which shows eosinophilic infiltrate within the vessel wall. Treatment plan. Treatment for Churg-Strauss depends upon the 5-factor score. 5-factor score currently which is being followed is age more than 65, cardiac insufficiency, renal insufficiency, GI involvement, and absence of ENT manifestations. If the patient has a score of more than 2, he has to be treated with steroids as well as a second-line agent. A score of less than 2 or a score of 1 is usually treated only with steroids. So, score of more than 1 is associated with more mortality, 18% mortality. So, treatment for them is systemic glucocorticoid as at a dose of 0.5 to 1 milligram per kilogram per day, and along with that a second line therapy. If we feel that the vasculitis is very severe as seen in impending respiratory failure, cardiac involvement, glomerulonephritis or even severe rapidly progressive neuropathy, the dose of prednisolone can be increased. If multi-organ dysfunction is present, then the patient is pulsed with methylprednisolone as initial therapy and then shifted over to oral glucocorticoids after improvement. The common second line agent which is used is cyclophosphamide. Cyclophosphamide is used in people with 5-factor score of 2 or more. It is also used in 5-factor score of 1 if cardiac or CNS involvement was one of the factors which gave the patient a score of 1. Alternative regimens which can be used in non-threatening diseases are azathioprine or methotrexate. Other options available are MMF, mepolizumab or IVIG. Omalizumab has also been tried, Plex and rituximab for severe cases. There's a recent review which has been done to see high dose versus low dose cyclophosphamide. This was done in people who are more than 65 years old, and intervention which was done for them was corticosteroids were given for 9 months and 6 500 mg fixed dose cyclophosphamide were given for 2 to 3 weeks followed by maintenance. In the control arm, they received 26 months of steroids and 500 milligram per meter square of cyclophosphamide pulse for 2 to 3 weeks, and then maintenance based on the 5-factor score. So this study tried to evaluate the severe adverse outcome in each group, and their primary outcome was to find out how many people had severe adverse events including death or debilitating conditions amongst each group. Secondary outcome was remission and relapse. They found that in the experimental arm, which is fixed dose of cyclophosphamide, there were lesser number of patients who had serious adverse events as compared to the conventional group. The deaths were also lesser in patients in the experimental arm as compared to the conventional arm. But they did not find any difference between the time taken for them to for survival. There was no survival benefit and there was no relapse benefit in either of those arms. At 3 years, however, they found that relapse-free survival rates were more in the experimental arm than the conventional group arm. So our patient presented with distal asymmetric sensory motor neuropathy with evidence of vasculitis. She fulfilled the ACR criteria. She did not have any end organ involvement, only a peripheral neuropathy was present. She had a FSS score of 1, that is absence of URI symptoms. She was treated with prednisolone and currently she is on follow-up.
Thank you so much. I think it always pays to have all the history and examination together to put together a diagnosis. You had highlighted the asthmatic history was running through, but what she came was anyway connected to it at the end of it. Any questions for Ruth? We're a very silent audience today, so you're forcing me to speak more. Any questions? You all can share from other cases that you all have seen which of a similar sort if there is. Thanks so much.